Also, sorry I wasn't here yesterday. I was not feeling well, and I guess I slept straight through my alarm because it's so early here. So I'm sorry about that. Um, but okay, so start with the epidemiology of the Chagas disease. So we did the Chagas disease, um, and it is caused by the parasite uh, Trypanosoma cruzi, which is also called the kissing bug, and it is a blood-sucking insect that feeds on humans and animals. And so infection is most commonly spread by contact with the feces of an infected triatomine bug. And infection can occur from mother to baby, contaminated blood products, an organ transplanted from an infected donor, laboratory accident, contaminated food or drink. And the laboratory accident and contaminated food or drink are the most rare. Um, and then the triatomine bug thrives in poor housing conditions, such as like mud walls, thatched roofs, and it affects people living in really rural areas, and it's most common in Mexico, Central America, and South America. So the social impact of the disease, like I said, it's most common in Mexico, Central America, and South America. And it's not transmitted from person to person or through casual contact with infected people or animals. Um, and so, I mean, that shouldn't stop you from being around people. And then if you do have Chagas, your family should be tested because they could have been infected the same way as you. And then if you give birth after being infected, the child should also be tested. And then if you're traveling, you should take precautions such as making proper sleeping arrangements. Stay in a well-constructed building because, like I said, they live in like mud walls and thatched roofs. And then just use bed nets to keep the bugs out. Using bug spray with long-lasting insecticides. Avoid improperly prepared food. And then later on, there's a picture of the presentation of someone whose eye is infected, and that can cause kind of like a social issue for you because if you like, it's very obvious that there's something going on with you, and so it can keep people I don't know, it can just kind of make them wary of you. And so that can lead to like loneliness, depression, anxiety because you don't want to go out into public looking like that. And you're scared about what people would think.
Okay, so some causes of Chagas disease. So, like Anna said, the cause of Chagas disease is the parasite Trypanosoma cruzi, which is transmitted by the bug triatomine bug. So, the way that this bug gets the parasite is it will go and bite an animal that has been infected by this, and they ingest blood, kind of like a mosquito, and sort of like how mosquitoes spread malaria or Nika virus. And so they ingest the blood and then they bite you and then ingest your blood and they poop on you basically. And then you scratch like the bite area. And that's when you spread the feces into your body. And so it gets into your bloodstream. So if you have been bitten, you really don't want to try and scratch the area, especially if you live in an area of risk. So, like Anna said, it's also not spread from human to human contact. So some symptoms of Chagas disease, they can range from mild to severe, or you may not even have symptoms at all. They can be acute or chronic. So some acute symptoms would be swelling at the infection site, fever, fatigue, rash, swollen glands, and then like Anna said, the eyelid swelling. And that seemed to be like a very prominent symptom for Chagas disease. I feel like every article that I found mentioned the eyelid swelling. So that was kind of interesting. And to me, the acute symptoms were very similar to the flu because of like the body aches, the fevers, the fatigue, and then the rash is just kind of similar to other rashes that you would get. So acute symptoms can go untreated, but if they go untreated for long enough and don't go away on their own, they can turn into chronic, and that is not good. So some chronic symptoms would be irregular heartbeat, congestive heart failure, sudden cardiac attack, abdomen pain due to enlarged colon, and then an enlarged esophagus. And these symptoms really are, in severe cases of Chagas disease, I thought this was really interesting that the chronic symptoms of Chagas disease may take 10 to 20 years to show up. So that kind of makes it a little bit difficult to diagnose, especially since most of these cases are in Central, Central and South America and Mexico. So they're in like poorer, more rural areas. And so it's a little bit more difficult to diagnose because number one, the healthcare isn't as good. And then you have symptoms that may not show up for years. So that makes it a little bit difficult. And then the organs that are most affected by Chagas disease are the heart and the gastrointestinal tract because of the inflammation, muscle atrophy, and fibrosis, which can lead to heart failure and esophageal and colon enlargement. So these are at risk because, like the heart, for example, since your muscles get so tired, your heart just kind of gets worn out from being tired because it is a muscle. So that can cause the heart failure, and then the inflammation will cause your colon and esophagus to enlarge. And then here's the triatomine bug or the kissing bug, and then the eyelid swelling that we mentioned previously.
Okay, so current treatments for Chagas right now is, so treatment is recommended for those diagnosed in the acute phase, babies with congenital infection, and people with weak immune systems, and like suppressed immune systems. So prescriptions are, that can be prescribed for it are benznidazole and nifurtimox, which can help during the acute phase. So benznidazole, I don't know how to say that, is approved by FDA for children ages 2 to 12, but it's not available in the US pharmacies. And the side effects are allergic dermatitis, peripheral neuropathy, anorexia, and weight loss, and insomnia. And then nifurtimox is also not FDA approved. No, it is. Sorry, no, it's not FDA approved. And the most common side effects are anorexia and weight loss, polyneuropathy, nausea, vomiting, headache, and vertigo. So they're only available in the U.S. Through the CDC, but they are available in the countries that are heavily affected by it. And so once in the chronic phase, because there's two phases, there's chronic and there's acute. So once in the chronic phase, medications will not stop it, but it can help slow the disease. And then there can be more treatment depending on certain symptoms. So if you have heart-related complications, treatment includes medications, a pacemaker, or other devices that can regulate your heart rhythm, surgery, or a heart transplant even. And then if you have symptoms that are more digestive related, you can have treatment that includes a diet modification, medications, corticosteroids, or even surgery. So blood tests are used to confirm the presence of the parasite, or it's used to test the proteins in your immune system and see if you have antibodies that were created to fight the parasite. And then there's anti-parasitic treatment. And so that kills the parasite, and it is the most effective in the acute phase. And it's used for all cases of acute or reactivated and chronic infection up to the age of 18. So this includes congenital infections. This treatment is advised for people up to 50. And then if older than 50 and you have a chronic infection, the decision to use the antiparasitic drug is up to them because there's many risks that come along with it. And so the older people, they have to weigh the risks and benefits for themselves and see if they want to keep using that treatment. And then there is symptomatic, and that can manage the symptoms and signs of infection, and it's meant for people with cardiac or gastrointestinal problems.
So future treatments for Chagas disease, there weren't a lot of studies being done on this that I could find, and I think that's because it can go for so long without showing symptoms or can be asymptomatic, and because of the areas where it's most prevalent. But I found a clinical trial that was done in 2019, and this trial is the Benazole New Doses Improved Treatment and Therapeutic Association Study. So basically, the goal of this trial was to find a new dosage of the current treatment, benznidazole, without making it less effective. And then they also did a study of a combined treatment with fluorouracil, which is a broad spectrum antifungal drug. So they did this study for 2 weeks. It was a 2-week course of treatment, which was just as effective as the 8-week treatment, which is very beneficial because it helps prevent adverse effects of the treatment. So you lessen side effects like that can just not be good. So, and then I also found one that was talking kind of about using synthetic drugs, but they didn't really have a lot of information on that one. So, and then there are questions and our sources.
You're muted, Dr. Daft, if you said anything.
I was testing you, Noel. Any questions for Anna and Olivia?
I have a question. So you said not to scratch your arm if you figure out you're bitten, but what can you do? Because if you like try to wipe or rinse with water, would it still get infected?
I think that water would help get it off. The purpose of not scratching is to not infect the area and get the feces into your bloodstream. So I feel like that would help some. It didn't mention anything like that in any of the articles I found. It just said to not scratch it. So, but that would make sense to use water.
Another question?
You mentioned that at least like one of the 2 drugs was not approved by the FDA, but they will still give it. The CDC will still give it if it's absolutely needed.
Yeah, I guess so. It seems like it's kind of like a risky drug to take, and so I guess they only want you to take it if it's like really necessary. And I don't think the U.S. is not a hotspot for this, so I don't think they really have to worry about it. But like in case you do get it, you can get it through the CDC.
Have either of you heard of any cases in the U.S.?
I didn't see any of them.
I didn't see any either.
Okay. Because we've actually found kissing bugs, I know in Alabama and Georgia, I don't know about Tennessee yet, that actually do have the parasite in them. It's not a huge number yet, and so we're not overly concerned, but kind of like the, I don't know, mosquito send-in, or not mosquito, the tick send-in thing that Megan talked about. I think Texas A&M actually has a similar program where if you catch what you think is a kissing bug, you can send it into them and they can test it. So it is here, right? Just not as big a deal, and mostly because you guys mentioned, right, in your presentation, housing has a lot to do with kind of transmission, right? It likes to live actually in between like cinder blocks or in between kind of holes in the clay of walls, and our construction's a little different here, so not as big a deal. My last question, if anybody else has one, we can totally do that too. But do you know like what the animal reservoir is? Because I know it's in the bug, but it gets it from the animal, right? The kissing bug gets T. cruzi from the animal and then transfers it to the human. You know what animals carry T. cruzi?
I didn't see anything like specifically of what animals. I'm assuming it's just kind of whatever is infected, because it wasn't really specific. So I was thinking maybe like strays probably would have it.
Okay.
Would be my thought, since they live in homes, or maybe like horses or farm animals might have it, but they didn't specify. So.
All right, interesting. Anybody else? All right, cool. Good job, ladies. Now let's
I want you to go next if you want.
You want to go next, Trent? By all means. Go ahead and load that up.
Well, maybe if my Mac decided it didn't want to be stupid and asked me to change my system preferences, give me a second.
Yeah, you got a second. Take your time.
Okay, so I've got to actually go out of Zoom for this to boot up. So
Okay, so I'll let somebody else go. Is that okay? All right.
Excellent. Okay.
yeah,
Can we? Oh,
Two.
sorry. I was wondering if Laura and I could go next then.
Let's do it.
Okay. Okay. Can you hear me? Okay. Unmute myself. Okay, there we go. So the disease Laura and I are going to be presenting on today is onychomycosis. It is a fungal disease that infects the nail. But before we get started, excuse me. Okay, I don't know what's happening. Hold on. Okay. There we go. Okay, so before we get started, I wanted to talk about the structure of the nail because it's important to understand the different regions that this fungal infection infects. So one of them it is the matrix, and it's going to be behind in this right picture, behind your proximal nail fold, and it's going to be underneath the skin. And this is important because new nail cells are creating new nail that's pushing the old nail out. So basically, if you get this infected, it will cause the rest of the nail that is growing to be infected. It's also important to know the difference between the nail plate and the nail bed because there are different types of onychomycosis. So a certain type will only invade the superficial layer of the nail plate, while some will invade underneath the nail plate, which is the nail bed, and the underside of the nail plate.
Yes, so like Noelle said, the part of the body that's affected is all of the nails. So that could include the nails of the hands or the nails of the feet, as well as the skin around the nails. So like she said, the nail plate is the visible portion of the nail, and the nail bed is the skin under the nail. And then it can also affect the nail matrix, which is also called the onychostroma, which is where the name onychomycosis comes from. And some of the symptoms of this fungal infection are, as you can see, these three pictures to the right. The top one would be an example of a cracked or brittle nail, and the other two would be thickened nail. And so the symptoms, other than that, are discoloration. So as you can see, the one at the top is kind of yellowy. The other ones are white. Those are common colors and symptoms for this fungal infection. Others are distorted nail shape and a foul smell, as well as dry, scaly skin around the nail.
So onychomycosis, which is also known as tinea unguium, is a very common disease. It affects 10% of the U.S. population, and also it affects 5.5% of the world population, which I actually did the math for that, and it's 240 million people have this disease. And 80% of the onychomycosis infections are caused by dermatophytes, and the main one being Trichophyton rubrum. Yeast such as Candida albicans and molds that are non-dermatophytes are agents of nail infections as well. onychomycosis is seen as a cosmetic disease by physicians because it does not threaten your life. You won't die from this disease. However, if left untreated in normal people, it can lead to athlete's foot and jock itch. However, in older patients, it could lead to cellulitis, which is an bacterial infection, which is dangerous to your health. And in diabetic patients, it could lead to foot ulcers. The history of onychomycosis is a German medical student by the name of George Meissner first described the fungal nature of it in 1853. And even though it was suspected earlier, most scholars give George the title of discovering onychomycosis. And the fungus T. rubrum that causes the most cases of onychomycosis originated in West Africa and the Eastern world. And a lot of researchers believe that troops from World War I, World War II, and the Vietnam War, when they were returning from battle, the boots that they wore are, of course, the perfect environment because it's moist and it's dark, and it's perfect to transport a fungus like this. So the first case of onychomycosis that was presented in the United States happened in 1937, and treatments back then were mostly just topical disease such as sandpaper, potassium permanganate soaks. However, in 1958, when Grisofulvin first was introduced, it was the first oral antifungal medication, and this doctors saw that it worked a lot better because it was able to penetrate the nail, unlike the topical treatments that they had before. Like I had said before, there are 4 types of onychomycosis, the first one being the distal subungual. This is the most common form, and it's usually caused by T. rubrum. And this specific fungus invades the nail bed and the underside of the nail plate. So if it grows too large, you could have your nail come off. The next one's white superficial, and just like it says, this fungus invades the superficial layer of the nail plate to form, like you can see in the picture, little white islands on the nail plate. However, the nail bed and the nail matrix are unaltered, and this accounts for 10% of the onychomycosis cases. The next one is the proximal subungual, and this fungus infects the nail matrix, which causes the newly formed nail plates to be infected. This is the least common form of onychomycosis in healthy people, but it can be found in immunocompromised patients. And candidal onychomycosis is a little bit different because it is caused by the Candida species, and it particularly just infects the fingernails. And the way that this happens, this infection is caused, is when someone has their hands submerged for long periods of time. That's why it is more common in women than in men, because in general, onychomycosis is more common in men than it is in women. And this specific fungus will penetrate the nail plate, and the soft tissues around the nail will appear red. And just like you can see in the picture, transfer white lines, such as bow lines, may appear on the nail plate. These are pictures of onychomycosis, and I just wanted to emphasize that like I said, there are different types, so they're all gonna look different. Like, for example, the picture on the left is a distal subungual. It's underneath the nail plate. It changed its color, and to the right, it infected the fingernails, and you can see the white lines, and that's mostly a candidal onychomycosis. How it is diagnosed is physicians will usually start with a physical exam first, and they will make sure to see if the nail is discolored, deformed, if the superficial layer of the skin around the nail is tough, if there's an overgrowth of the nail, or if there's any subungual debris. If these symptoms are shown, then they will clean it with alcohol and then collect samples. And once they take the samples, they'll look it under the microscope using potassium hydroxide. And the reason why they use potassium hydroxide is because it's good at breaking down keratin to make it easier to identify the organism that's causing the infection.
So one of the most common things that people think is that onychomycosis is very similar to athlete's foot, and that's not necessarily true. So the previous pictures that we saw were onychomycosis, and this one to the left is athlete's foot, which its scientific name is Tinea pedis. And this is a fungus that attacks specifically in between the toes, and onychomycosis attacks, as I said, the nail bed, the nail plate, and the skin around the nails. So that does not include in between the toes. And for athlete's foot, it typically causes a scaly rash and itching, stinging, burning. And this one, onychomycosis isn't usually transferred from person to person, but athlete's foot can be transferred from person to person much easier through wet areas such as like locker rooms, or from person to person through towels or clothes if you share socks or anything like that. And there's a lot of prescription and over-the-counter medications for this infection. And so for how does onychomycosis cause disease? Like we said, it's caused most prevalently by a fungus called dermatophyte. And there are other nail infections which can be caused by yeasts and molds, but those aren't onychomycosis. Onychomycosis is separate from those. And onychomycosis is most often occurs in older adults, and that's because of the lack of blood flow and circulation to the foot and the nails and the hands also, because it can be in either place, which can cause cracks and brittle nails, allowing the fungus a great place. They love to just get in those cracks and start to harvest there.
How the disease spread is onychomycosis is contagious. It is transmitted by direct contact and coming in contact with materials such as shoes and socks, and walking barefoot over the surfaces with high density of fungi. To prevent the spread, you just make sure that you always clean in between your fingers and your toes, and make sure you keep your fingers and toes dry. If you are tending to your nails, wash your nail clippers or clean your nail clippers or other equipment that after using them. If you have shoes that have come in contact with your nails, discard them, or if you want to keep them, just make sure you treat them with disinfectants and antifungal powders. Make sure you wear shoes with good air circulation, and do not wear nail polish and artificial nails, because that is a really good environment for the fungus to get in between that fake nail and your nail and start manifesting there. The people who are most at risk for this disease are adults 60 years plus years of age. And like I said, this disease does affect men more than it does women. It also affects patients who have had previous fungal infections such as athlete's foot. Patients who have diabetes are also at risk because of poor blood circulation. And even though this disease is not hereditary, there are families that have genes that make them more susceptible to fungal nail infections. It's not as common, but it does happen. Risk factors of how you can get onychomycosis is having sweaty feet for long periods of time, walking barefoot in damp areas such as locker rooms or pool areas, using communal or shared showers, wearing artificial nails, and having a history of athlete's foot or previous fungal infections.
So next is cultural impact, and really the reason why Noelle and I chose this is because both of us have several people that we know that suffer from onychomycosis, and we know how difficult it can be for their mental health and cultural impact. For the people I know specifically, it could be embarrassing to have on your fingernails if you're in like a job interview or having a job meeting and some stuff like that. I know the people that I know usually put like a Band-Aid on their fingers since it's only on a few of them. But if it's on your toes, it can be a little bit easier to cover up, but it's still embarrassing. You might not want to wear open-toed shoes or things like that. And this can really lead to some mental health issues, like I said, some depression and anxiety and things like that. So there are a lot of current treatments for onychomycosis. Since it is a chronic disease, it can last for years or definitely a lifetime. So there are topical treatments, which could be foot soaks or nail creams, which are also called nail lacquers, that can be used, and those are cyclophyrox and amlodipine. But topical treatments don't typically work because due to the hard structure of the nails, topical treatments can have a really hard time penetrating and solving the problem. And for a person that has onychomycosis, maybe they've had it for years or their whole life. If they really just want answers and they want to fix the issue, this can really just elongate the problem. And really, if it doesn't work for them, which it really doesn't work all that often. But they do have oral treatments, and like everything though, these do come with side effects and disadvantages. These are a longer treatment period, so you might have to take it for a longer amount of time, but usually they're more effective. But they do cause sensitivity to sun, they could cause headaches, diarrhea, or rashes. But typically oral treatments is what works for most people.
And so some future treatments for onychomycosis is Novaxetin, which is a topical treatment. And the problem, like Laura said, in the past with topical treatments is they were not able to penetrate the nail. However, this specific topical treatment does effectively penetrate the nail. And usually for topical treatments, they use some type of enhancer to make sure, like, to help it out. But for this one, they did not need it at all. And also, like Laura said, that they usually recommend oral medication. However, that does take a long time to come into effect, and 38% of patients, usually after a year of usage, only show a little bit of effectiveness with using the drug. However, with Novaxetin, it only took 4 weeks for 56% of the patients to notice a difference. The next is uraclocine, which is a broad-spectrum antibacterial and antifungal agent. It is usually used in pink eye, conjunctivitis, impetigo, and urinary catheter infections. But in some preclinical trials, they did see that it treated or helped treat onychomycosis by penetrating that nail and getting rid of some of the fungus. And some other future treatments are laser treatments, and usually this was used for a cosmetic, to make the nail look better, but it was never really long lasting. But this laser Nd:YAG uses the ability, most lasers use the ability for heat transfer, but this one's really good at improving your local circulation around your fingernails and your nails, which is very important, as well as it improves your body's natural immunological response. Also, researchers are trying to test a combination of laser treatments and topical treatments, because lasers are really good at penetrating, but topical treatments are really good at treating the infection faster. So one example is fractional CO2 lasers and terbinafine. However, they've tested this, but still, like, in the works. I think they're still going. They're in the second trial of this test. So, and then this is our question, or one of them, and blank is the most common form of onychomycosis and invades the nail bed as well as the underside of the nail plate, which is distal sublingual.
And our next question is, which of the following is not a symptom of onychomycosis? And that would be the loss of the cuticle.
And then this is our sources.
All right, cool. Questions for Noelle and Laura?
You said that, like, it affects men more than women. Do you know why it would affect men more?
It didn't really say, but for no, it did. Okay, so women do end up wearing certain types of shoes like sandals and open-toed shoes more than men do. And men, of course, in the perfect environment for this fungus to form is wearing socks and wearing closed-toe shoes. But that's really all they said about that. They didn't really go into any like in-depth explanation.
Any other questions?
I have a question. Is it curable or not? I might have just missed that, but I was kind of a little bit confused.
Yes, but it can take a really long time to cure it. Typically patients with this disease suffer for it for a very long time. But like I said, like the topical treatments don't usually work for all that many people, but the oral treatments usually start to take away that fungus as they are on that treatment.
I liked it. I'll just let you know. Well, I guess I'm a survivor-ish. So I have it on 2 toenails on my foot, and it developed in one of my toenails in grad school. And I went to the doctor, and she was basically like, "It is cosmetic. Just get some over-the-counter like treatment." And she kind of rubbed me off. So, I think some doctors probably take it more seriously than others. Yeah. Cool. This one touched close to home. I love it. All right. Any other questions? I'm trying to see if I had anything here. Oh, I actually had a question. I don't know if you could tell me this. So are you saying that patients that have this are more prone to develop athlete's foot and jock itch, right? Because you're saying those are different fungi that cause those, or is there transfer from toenail? You know what I mean? I'll just say the jock region, right, is far away from toenails. And so are these people just more susceptible to fungal infections? Or, you know what I mean? Like, how did you see how that worked or what the association is there? I thought that was kind of interesting.
Yeah, so when people come in contact, like if they have it on their fingernails or if they have it on their toenails and they're touching and they're not, usually jock itch happens more in men than females, of course, not of course, but they would have infected nails and then they'd end up scratching their genital region, and that's how like it would transfer. Okay. You know what I'm saying?
Yeah, I got you. Very interesting. All right, cool. See, washing your hands is good for a lot of different reasons. I like it. All right, good job, ladies. I don't know if Trent's back or not.
Yeah, I'm good.
You ready?
Yeah, just Apple was being stupid, so.
All right. All right, Trent, whenever you're ready.
All right, so we got polio. Pretty common condition back in the day, but we really don't hear a lot about it now, so let's learn. History of polio. So polio epidemics predate recorded history. The earliest known sign that there was polio outbreaks is seen in a Egyptian hieroglyph that was recovered in Alexandria, Egypt, of a man suffering from what's called post-polio syndrome, or PPS, and I'm just going to abbreviate that for the rest of the go. But he had a deformed foot in the hieroglyph, and it was kind of like decoded as polio. The first time it was described by a medical physician was in 1789 by Michael Underwood. Clinically described symptoms in 1840 because they started to realize it involved more spinal nerves as medicine became more advanced. And then the first U.S. outbreak was in 1894 in Vermont with 132 cases, and it showed more of the general symptoms, and the largest outbreak in 1916. Okay, so what is polio? Polio is a virus. It's a disease caused by the polio virus, and it affects the spinal cord, specifically causing some muscle weakness, deformities, and paralysis eventually in later stages. There are currently 3 identified strains. They are P1 through 3, really simple labeling. They used to have longer names, and that's going to go on in here, but they really shortened it up and helped us out a lot. So what it centrally does, it multiplies in specialized nerve cells and in the intestines, and will travel to the CNS, and it will do programmed apoptosis and destroy motor neurons specifically, and that'll cause resulting syndromes. It can cause a form of meningitis. It can cause complete paralysis. It can cause respiratory distress and death because of that. Generally, most things seen with PPS is lower body affected because of the fact that spinal nerves grow up the spinal cord, and it's going to travel and hit those lower spinal nerves first. So your legs would be affected more so than the torso. So how is it transmitted? Polio is highly contagious from person to person contact, and it lives in mucosal membranes in its early stages. So the biggest like person-to-person contact, other than the feces, which is on down here, is actually kissing. So it's similar to mono in that situation, because if you kiss somebody who is currently contagious with polio, then you're definitely going to get it. It's like 100% effective. The most common transmission, though, is feces. So make sure you're washing your hands, because polio is shed in the feces. And live viruses can last for a while on there. And so whenever you touch something that's been in contact with polio-infected feces and then immediately touch face or other mucosal membranes, then you're almost guaranteed to get it as well that way. That's mainly seen in a lot of countries that have lesser hygienic standards, and like communal baths, things like that. Because the highest outbreaks the highest known outbreaks in the world is still in India, and it's the only one that's currently having outbreaks. I think there's a couple of cases in like the Congo, but generally it's India right now. So incubation, like I said, it can live in feces for a long time. It can live up to 5 weeks, and during that time contaminate food and water in some unsanitary conditions. It can be completely asymptomatic, so we don't know what the general time is, but the official incubation time listed by the CDC is 2 to 35 days, so it just depends. And that also depends on the person's immunity and microbiome. It can be seen very quickly in immunosuppressed patients, but then also you can just be completely asymptomatic, so they don't know for sure. So largest groups that are at risk would be pregnant women and people on immunosuppressants, so like cancer patients. HIV positive patients are really prone to getting polio. If they travel outside of, like if there's somebody from the US or the Western Hemisphere and travel outside of the US without being vaccinated first, and they're really, really likely to get polio. And so more of the social impact of it, it's kind of debilitating quality of life because it does lead to pure paralysis and PPS. So it can also cause malformations, especially if it's in a younger individual, because polio can be transmitted from birth, especially during live birth, because feces is a common occurrence with live birth. So the baby can get it very quickly during live birth. And so that can cause later deformities. And then if it's a later stage symptom of PPS, or if the poliovirus infected some of the higher up torso spinal nerves, then you can have life in an iron lung, which I think the oldest person that was still living in an iron lung just recently died. They were like 80 and they'd been in there for 60 years. So it's a whole process. So viral descriptors, it's a 25 to 30 nanometer virus. It's got a lot of really the scientific descriptors. This is from a research paper actually on polio in 2014, where they're trying to develop a new vaccine, hopefully would go against resistance. But it does form a beta sheet and beta barrel. and then it does have lots of antigen sites on it, so it's kind of easy. And then there's the prototype strains, which is what eventually became types 1, 2, and 3, and it was just named for the scientists that are working on them. So the true pathogenesis, polio does enter the oropharynx most of the time, and that's just due to feces contamination and people putting their hands in their mouth. It multiplies locally in the tonsils, neck lymph nodes, and the small intestines. And then there's a hypothesis that actually, because it's been seen in 5% of the cases, that the polio virus will actually enter the bloodstream first and then travel to the tonsils where it will continue to multiply. But since that's only seen in such rare of cases, the common acceptance is that it's just oral transmission. And then after 3 to 5 days, the virus is shed in the stools of an infected person, where it can again live up to 5 weeks. So yeah, watch out for the feces. Signs and symptoms, it can be completely asymptomatic, but it does present like just a general viral infection. So flu-like symptoms in most cases, if you do have symptoms at all, which is still pretty decently rare, especially in today's day and age, or being in the Western Hemisphere. Weakness, fatigue, and fever are the most common symptoms. But then gastroenteritis, because it does affect the GI tract first, gastroenteritis is a common descriptor. And then respiratory tract infections. So if it's in more of the stage 2, I guess you could say, of its pathogenesis, then it will show some respiratory infection signs. And then antibodies will reach the CNS in 7 days via the bloodstream, but it takes a little while for that to happen, because if the antibodies have already reached the CNS, then the virus has already reached the CNS and you can have damage there. So the virus actually destroys motor neurons specifically. So it likes to cause damage at the anterior horn of all the spinal cord neurons, and that'll cause limb paralysis just due to motor and afferent nervous tissues and how they operate. It really does a good job of being a attacker, because it'll accumulate the plasma cells and neutrophils and microglia for an immunoresponse, and it'll cause phagocytosis with the actual infected nerve cells. And because nerve cells is non-regenerative, then it will just completely destroy that part of the spinal cord affected. And so that causes flaccid paralysis, to where basically, because the nerves can't move at all, can't move the muscles and the musculoskeletal system, the entire muscle atrophies to the point where it's non-effective at even being a muscle. It's barely even there. But most of the deaths that's occurred to polio is due to a respiratory paralysis, to where the diaphragm completely stops working. And then something I thought was really cool is that PPS can actually occur up to 30 years after the initial attack, because of the ongoing neuron degeneration. So it might start with just some really small portions of the axon, to where the nerve is still functional, but over time your nerves degenerate anyway, and it'll show signs of PPS even up to 30 years later. And then rare cases can persist with some mutated cytokines, and that will attack the brain and spinal cord, leading to Alzheimer's and dementia-like symptoms, which I thought was interesting. So some of the past treatments. Past treatments of it was kind of like a hit or miss, trial and error. Originally, the scientists at the time thought it was bacterial, especially in the early 30s and 40s, whenever penicillin was the new hip drug to throw at everybody. So since they thought it was bacteria, they're like, oh yeah, we're going to throw some penicillin at it, and it actually worsened their conditions because of the microbiome within the GI tract, and it continued to worsen, and it allowed the environment for the polio virus to continue and be really susceptible, because they don't have that good bacteria to help fight it off in the gut. And then also lumbar puncture, which was kind of odd. So they essentially just started draining CSF, and that did absolutely nothing for it, but that was the common treatment up until 1956, which was yeah, it's one of those things that's kind of scary. With FDR having polio and him being treated as a senator, in Georgia with the polio research facility there. They did spinal taps on him once a week. So I thought that was really odd for him. And then iron lungs were the main treatment. So an iron lung causes a positive pressure system within a defined box. It looks like a really big metal coffin, and it'll force air into the lungs, which helps relieve the workload of the diaphragm. So it allows prolonged life expectancy, especially with respiratory failure. But that's the gist of the iron lung, really, is that with polio, you're eventually going to die of respiratory failure. So more conventional treatments, they use a disinfectant called urotropine, and urotropine is basically an acidic disinfectant. It breaks down to formaldehyde and ammonia whenever it is injected into the bloodstream. And so the formaldehyde will go in and it'll kill all the infected bacteria. But then also the ammonia will kill any live viruses that are still seen in the bloodstream, just as a general cleaner. It's a very low dose just because of how potent, and it changes the pH quite drastically within your own system. So they use a very low dose for that. And it's also given in conjunction with vitamin C as an immuno booster. And so there has been a vaccine since 1955. And that was developed by actually Jonas Salk, who's one of the great fathers of vaccines. So that's really cool and just fun facts. The vaccine was given as part of your childhood immunization, so like your kindergarten shots and such, up until 1991. And that was like the last time it was officially in that same combinations with like MMR. And so the vaccine, like you can still get it today. And that's the most common treatment, is just to go ahead and get the polio vaccine, but it's only given to people who are traveling outside of the US and Europe into areas that have had a recent outbreak. The polio vaccine does use deactivated poliovirus, and it's since 2000, it's only used for people that are experiencing outbreaks in countries. They're really not future treatments because of the fact that it is 99% effective using urotropine and vaccines. And it was completely declared eradicated from the US and Europe in 1979, and then completely in the Western Hemisphere in 1991. So the other part that is how we can help just in fighting this kind of virus, because it was so widespread. The March of Dimes Foundation, originally started by FDR, continues to contribute to polio, and it helps people in other countries that are experiencing polio outbreaks, specifically India at this time, and India, and then a lot of African nations in the sub-Saharan Africa, like the Congo, experience polio outbreaks on the regular. And then some questions on here: is polio virus true? Is polio is not treatable? Answers false. And there's my sources. And do we have any questions?
Questions for Trent.
I have a question. So, if someone with polio came to the United States, would it just I don't know, would everyone just gets polio because we don't use the vaccine anymore?
So herd immunity is really large at this point. Most of our parents got the polio virus vaccine at the time, and that is one of those viruses that is, or one of the vaccines that suppressed people can get still and use horizontal transmission, pass it on. And then also people who were born with live birth, that's one of the few antibodies that is passed on through placental transfer. And then also breast milk transfer is one of the cool immunoproteins there. But if somebody came from the US with polio, we wouldn't get it, because if they came to the US and had it, it would most likely be non-contagious, just because you're either going to show the contagious period on that is like 3 days. So.
Any other questions? Come on, one more.
Do you know about like the vaccine? Like if it was one that was just it's like given one time, or if they have to like have a booster for it?
No, the vaccine is just a one-time thing. It's kind of like smallpox. It's one and done, and then it leaves a big scar. So
Yeah, and I'll just add to that. If you are older and are traveling somewhere, some places will recommend, even if you had it when you were a kid and you're traveling now, they'll recommend like a booster. But yeah, I'd say a pretty hardy vaccine as far as longevity. So, all right, cool. I like it. Let's take a short break. It's 9 o'clock. Let's come back at like 9:10, and then we'll finish these up. All right. Good job, everybody that's gone so far. So take about a 10-minute break.
Okay, so a brief introduction. So Cryptosporidium is a microscopic parasite that causes the diarrheal disease cryptosporidiosis. Its parasite and the disease are commonly known as crypto for short. So the parasite can be spread in many ways, but water is a major way it's spread, both drinking and recreational water. So like swimming pools or like lakes and things like that. And although crypto can affect all people, there are particular groups of people that are affected more, like immunocompromised people, and these are people like with HIV, or as we read in our transplant paper, people that just on the that had a transplant because like they're on immunosuppressant, so they're at higher risk for developing this disease. Okay, so a brief history on the disease. Crypto was first described in 1907 by Edward Tyser in the gastric glands of mice, but it was not until 1976 that it was first reported in humans. It's an endemic in both the United States and United Kingdom, and although it's seen in other countries, it's not seen as much as it's seen in the UK and in the US. So the distribution, crypto is not the most common cause of waterborne disease in the United Kingdom and has been associated with drinking water and swimming pool contact. So like people who go swimming, like that's where they mostly get like infection too. So although it's not quite so the link between crypto infection and drinking water led authorities in both the United Kingdom and United States issue advice to immunocompromised people to boil their water before drinking. So the crypto oocytes at like 62 degrees, it gets inactivated. So due to the fact that it's selective for like immunocompromised people, the UK and the US like passed like an issue to like immunocompromised people to make sure they boil that water before taking it so as to kill the oocyte. Okay, so as I said earlier on, the individuals at high risk are immunocompromised patients and recreational swimmers. So the spectrum and severity of the crypto disease in immunocompromised individuals reflects the importance of T-cell response in dealing with the disease, because most severe diseases in individuals with defects in T-cell response. So as we said when we're talking about our immune system, like the T-cell is like has a major role in fighting off pathogens and things like that. And we see that immunocompromised people, they have like a reduced like immune system, so they can't fight it. And as Caroline will discuss later, there's no like really effective drug for treating crypto, so it's really spontaneous recovery, and it has to do with how like the strength of our immune system and how much it can like fight the disease and things like that. So we can, and when we compare like the infection between healthy individuals and immunocompromised individuals, we see that in healthy individuals, crypto typically causes a watery diarrhea with abdominal pain, and it lasts from like several days to like weeks, and it depends on how fast like your body can fight with the pathogen. That's how it will last. But in infected people who are immunocompromised, they suffer a more severe and prolonged gastrointestinal disease, which can be fatal. And also, body systems other than the gastrointestinal tract may be affected in immunocompromised patients. But in healthy individuals, it's like the parasite is really just limited to that gastrointestinal tract and not to like other like major places. Okay, so spread and control. Crypto is mostly spread by putting something in your mouth or accidentally swallowing something that has come in contact with stool of a person or animal affected with crypto. And swallowing water or beverages contaminated by stool from infected humans or animals. And so when I was like writing this part out, I keep thinking of people who go to fish and people like eating like snails from lakes and things like that. So like when you're doing all those activities, like we have to be careful of like where we're actually fishing from, and like the seafood we get, like we have to also be careful of like where it is, because we could easily just they could easily carry the oocytes and we'll just eat it and we could be infected. So we have to ensure that we don't eat contaminated food and like we cook our food very well, because the oocytes that are 62 degrees Celsius, so it's not so high. So like cooking your food well, making sure it's like boiled well or fried well will help kill and inactivate the oocytes. So ensure to avoid unclean public pools, ensure to boil water from an unsure source, and also wash your hands before and after eating. We can't emphasize the importance of like washing hands. It can like help kill a lot of pathogens, and it can help kill a lot of pathogens and also help avoid a lot of diseases. Okay, so to current research. So even though I said that crypto is a major cause of waterborne disease in the United States and United Kingdom, research has been limited because the pathogen is intractable and there's really hardly any tool to get drugs or learn more about the pathogen. And I said earlier, and currently we discussed more about it, the current drug use is not really as effective as we want it to be, but still a lot of research isn't done on it. But I found an article, like a research article, it was done in 2018, so it's still pretty recent, and like the scientists are trying to do like a novel cell culture to like develop and grow the parasites, the crypto parasite, in like a cell culture dish. And what I found really interesting is like they stimulated the environment of the cell culture to like resemble the gastrointestinal tract, and this will make like a more like comfortable environment for the parasite to actually grow and propagate. And they saw that the crypto parasite could propagate for like 6 months, up to 6 months, which was, to me, I found really interesting. So this will be beneficial because then the scientists can see the developmental stages, and they can like try to like target drugs and see like, oh, like what drugs like work, what drug can kill them at what temperature and things like that. And it could also help them know like the pharmacokinetics and pharmacodynamics of whatever stuff drug they decide to test on. And since they're very limited drugs, I think this will help out to like develop new things. So I found that really interesting. I think there's one slide, the social impact. Okay, yeah, social impact. So apart from knowing the symptoms of crypto, it's also important that we know the cause and the symptoms and how they affect the emotions and socioeconomic aspect of infected individuals. So a major symptom of crypto, as I mentioned earlier, is diarrhea, and this can make an infected person very uncomfortable because like diarrhea comes with like abdominal pain. It comes with like sound, like your stomach making like gurgling sounds, and like you always have to use the toilet, and it causes nausea and vomiting. And if I were to be in that situation, I would be extremely uncomfortable. And if I were a child, like an infant, because they talked about this, and if I were an infant and like I was in sole like care of my parents, them always having to take care of me and clean up after me, it will affect them from going to work. It would just be pretty uncomfortable, and also uncomfortable to people that will be in the care of an infant individual. Also, most immunosuppressed people can't undergo recreational activities like swimming. And I love swimming. Swimming is my favorite sport. So having to not be able to do that would be really sad and really annoying. So yeah. Also, infected people have to ensure to rest in order to get better because, as I said, spontaneous recovery is how people mostly get better from these diseases. So they have to like make sure they stay at home. So they can't go to school, they can't go to work, and this will affect the economic aspect of the individual's life, and also the educational aspect because they can't go to school. Yeah, Caroline.
Okay, so I'm going to talk about how it gets in the body and infects. So Cryptosporidium, in its infectious stage, it's an oocyst, which, as Tommy mentioned, is a very, it can survive lots of environmental things. So, and one thing about pools is, like, even in chlorine, chlorine doesn't kill the oocysts even. It takes like multiple days for them to kill the oocysts. So, and oocysts are about 5 micrometers in diameter, which, for size comparison, a human hair is on average 100 micrometers. So the oocyst enters the body, and when it's triggered by the pH and temperature changes in the stomach, it opens and releases 4 sporozoites, and that's pictured over here. And then to infect the host, they attach to the epithelial lining of the intestinal tract, specifically the ileum, or like the top part of the small intestines. And so the way that they attach is kind of interesting because they don't go inside of the cell. They don't become intracellular, but they are intracytoplasmic, which is how they do that is they just attach onto the outside of the cell, and then they cause the microvilli to fuse together and surround it. And then they can get nutrients out of the cytosol from the cell. So that's how they get their nutrients. And then at this stage, they kind of round out, and they're called trophozoites. And then they have 2 methods of reproduction. The first is the asexual reproduction, which is where the trophozoite just replicates by binary fission, and it creates type 1 meronts, which release merozoites, which merozoites basically are the same as sporozoites, where they just infect the host that way. They attach to the epithelial lining. But then in the sexual reproduction, the trophozoite becomes a type 2 meront, which creates differentiated cells. I guess you could call them male and female, but when the female merozoites attach to the epithelial lining, they become macrogametes, and then when the male merozoites attach to the epithelial lining, they grow to become microgametes, which then are released, and then they fertilize the macrogametes, which produce a zygote, and then that grows into either a thin-walled oocyst or a thick-walled oocyst. And then the thin-walled oocysts, they just reinfect the host, but then the thick-walled oocysts are released in the host stool to reinfect another host. And then this is just a picture of the whole cycle. And then for symptoms of cryptosporidiosis, it does take just 10 of the oocysts to become sick. So not very many, because it's easy to get that many at one time. But the most common symptom is watery diarrhea, which makes sense because it's the body trying to flush these invaders out. But then also because the trophozoites that are attached along the epithelial lining cause the microvilli to fuse, and that leaves way less room for absorption on the small intestines. So, like, of course, it's going to be more watery. And so, but then other symptoms include stomach pain, nausea, vomiting, fever, and weight loss, which
can be worse or better depending on how bad the infection is, and also obviously immunocompromised patients do get it much worse because of the lack of T cells and other cells, other cells to combat the disease. But some patients do require hospitalization just to replace the fluid that they're losing through diarrhea, because it can get pretty bad. But for some, this diagnosis of this could take some time because the symptoms can be fairly general, and for most people, they are pretty mild as well. And so it could, like other diseases, have these symptoms, so it could take some time to diagnose this. And then symptoms generally last around 2 weeks, but it can vary between people. And then there are around 1 million oocysts and a gram of fecal matter at the disease's peak. So it's pretty easy to see them when there's staining done during this period. So they use bright field staining and acid-fast staining in order to see the oocysts. And this is it pictured over here. And then for treatment, there are no specific treatments for crypto. Like there's nothing that actually like combats crypto itself, but nitazoxanide is FDA approved to treat it, but it just treats the diarrhea. Also, one article talked about anti-motility agents being used for this because it slows the movement of the intestines, allowing for more absorption time. So it lessens the diarrhea. And then obviously drinking liquids to replace the fluid loss is very important for this disease, just to replace the fluids. And then these are our questions. So why did the US and the UK government advise immunocompromised individuals to boil their water before use? And it's because the crypto or oocytes are killed at 62 degrees Celsius after just a few seconds. And then also, why are immunosuppressed patients more susceptible to getting disease crypto? And the answer is because the T cells are responsible for attacking the disease, but in immunocompromised patients, there are less of them. And then these are our sources.
All right, questions for Toomey and Caroline. I'll start to inspire you. So is this only found in fresh water, or can this survive in salt water? Do you guys see that?
Yeah, I saw that. So it could survive in both. It's not halophilic that it loves salt water, like it loves salt, but it could survive in like moderately like salty water, but it's not like halophilic. But it can survive in both fresh and a little bit like moderately salty water.
So, but I mean, are infections more common in fresh water? You know?
I don't know that. Okay. I don't know if Caroline knows anything about it.
I would think so, because a lot of time, like, infections start by things getting into fresh water sources that we then drink. Like, there was one case in Milwaukee in 1993 where, like, crypto got into the water somehow, and then, like, half of the city got infected because of just it was in the water. So I would think fresh water would be more common.
That's a lot of diarrhea.
Yeah.
All right, another question from somebody else other than me.
Are there like hot spots in the United States where it's more common, or is it pretty diffuse throughout?
I'll say it's diffused around.
What about in relationship to Lauren's question? Are there times of the year that are hot spots? So when swimming pool season opens back up, right, which may not be as big a deal this year because you probably don't have as many people. But is the summertime, is there an uptick of cases as people start going to lakes and going to swimming pools? Did you see anything in that regard?
Sorry, Caroline, remember the research you said about like the outbreak? Do you remember the period it was in?
And the one in 1993?
Yeah.
Yeah, that one was in, I don't remember what time of year that was, but like I would imagine that around
It was in
summertime and when a lot of people are swimming, it would be more common. I didn't see anything about that, but like it would make sense.
One other question. Come on.
I don't know if this would have come up in your research, but I was wondering, you mentioned like boiling water would remove it from being a contaminant. I was wondering if you saw anything about like hand pumps or filters that are used pretty commonly now in like camping, like where you pump the water through a like porcelain membrane to like try to keep stuff from getting into your drinking water. Do you know if that would prevent the crypto from getting in?
I think it would depend on the pump. In Milwaukee, the water case, like it was a case of their water filtration system not being quite tight enough to catch the oocysts from the crypto. So I guess it would just depend on the water pump you're using and like whether it's like, I don't know, whether it catches that, but yeah.
I like that question, Megan. I'm going back in 2 weeks, and this lecture made me nervous.
Also to add to
I'm
what
taking one of
Caroline
the handheld pumps for my drinking water.
to add to what Caroline said, it's actually pretty small. Like your sites are very, very small. So we have to like make sure like even if we're pumping it out, our filter system has to like the pores or the holes has to be tight and like secure because your sites are pretty small and could like pass through some filtration system. So we just have to be careful of what we buy and make sure that it's pretty tight and doesn't have like holes or stuff like that.
Okay, cool stuff. Let's see, who do we got left? Allie and Rachel, and Mercy and Elena. So who would like to go?
Rachel and I can go.
All right, let's do it.
Okay, so Allie and I, we chose tuberculosis for our disease. And it has kind of a pretty broad history. So the first, like it's been known to mankind since like ancient times. So the earliest dated was in Egypt in 3700 BC, so quite a while ago. And in 1500, TB was thought to be contagious, and that was actually proven about 300 years later in 1865. And in the 1860s, it was thought to be spread by airborne transmission, that was the case, and it wasn't until the 1930s that was proven. But one of the most important dates was in March 24th, 1882. Dr. Robert Koch announced his discovery that the bacteria that causes TB was Mycobacterium tuberculosis. At that time, TB killed 1 out of every 7 people in the United States and Europe. And this discovery was a super important step in controlling and eliminating the disease. And in the 1940s, 50s, and 60s, some of the drugs we actually still use today, which Allie will talk about later, were developed, and those were huge steps forward in the controlling and eliminating TB. But with TB, we've kind of taken several steps back due to, in the 1970s, the first case of multi-drug resistant tuberculosis emerged. And in 1993, the World Health Organization announced that TB was a global health emergency, in which they called it the forgotten epidemic because it was so underestimated and so many people didn't really take it seriously. And in 2006, the first case of extensively drug-resistant TB was reported. In 2011, there was at least 1 case of extensively drug-resistant TB in 70 countries. And extensively drug-resistant TB is where the TB is actually resistant to isoniazid, rifampin, and any fluoroquinone, and at least one of the injectable second-line drugs that we used for the disease.
Tuberculosis is spread when a person who has the bacteria in their lungs or throat either talks, coughs, or sneezes, and that spreads the droplets through the air. And there are two versions. TB disease is the active version, and that is when the bacteria are in the body and multiplying, and the immune system is not able to keep up and stop them. Latent TB is when someone has the bacteria in their body, but it's not actively dividing, so it results in no symptoms, and that also means they're not able to spread the disease to others, although it may and probably will emerge later in their life into the active form. So a few ways that TB is not spread is by shaking hands, eating or drinking after someone else, sharing toothbrushes, touching bed linens, or kissing. And those with TB disease are most likely to spread it to people who they spend the most time around, such as family members, friends, coworkers, and classmates. People who are most at risk for contracting tuberculosis are those with weak immune systems, especially those with HIV. And this is because they cannot fight off the infection well because of their low immune system. Other factors could include poor nutrition, poverty, poor housing, substance abuse, which all impact the immune system and can make it harder to fight off the bacteria. Also, if you're living in an area where TB is more common, especially urban areas, you would be considered more at risk simply because there's a greater chance that you'll be exposed to the bacteria. Those who are homeless, living in poorly ventilated areas or overcrowded areas are also at risk because the bacteria can spread more easily when you're in close proximity. It can actually last in the air for about 6 hours, but under those specific conditions, it could stay in the air even longer just because of the poor housing conditions.
Some of the effects of like the disease, like on life outside of physical health, to be able to work in the medical field, you have to get a TB skin test, just as a precaution. It can affect performance at work or school because maybe you have to miss, maybe your symptoms are a little too strong. There's several things that it can affect there. You can actually not donate blood if you have active TB or if you are on the antibiotics for it. I did read that for latent TB, they are kind of picky about it. It's not completely prohibited, but they really might not let you. And so mental health and social life can be really affected due to TB because it is so contagious. You do need to stay away from other people. And so I think kind of like what we're seeing with the coronavirus and staying in quarantine, though those particular things are more affected than what we thought that they would be. So the pathology of TB, so TB is caused by Mycobacterium tuberculosis. It is a small bacillus. So like Ali said, when somebody sneezes or coughs, those air droplets will actually go in. Once it's in the lungs after transmission, the bacilli are actually ingested by macrophages that recognize it as foreign, and they try to eliminate it by phagocytosis. But what actually happens is the bacilli can actually replicate within the endosome of that macrophage. And so as that immune system is trying to ward off the disease, the macrophage will form a granuloma, which contains the infected macrophage. This is actually the hallmark of TB, that it actually forms that granuloma. And in the core of that, the macrophage is infected, and it'll be surrounded by foamy macrophages, phagocytes, and lymphocytes. And that will form actually a capsule that will be a place that the bacteria can hide. And so that a granula can either proceed to sterilization of the infection, where it will actually be latent TB, where it's not dividing, or it can actually continue to grow and release several thousand infectious bacteria into the lymphatic system. And then due to that it growing so much, you have so many that are released, and then the cell will lyse, and that's active TB, where it's continually growing and spreading.
Are we okay? What's going on?
Allie, I think you're muted.
Sorry. So the most common symptoms of TB are a really bad cough that lasts 3 or more weeks, fever, loss of appetite, and then you can also have weight loss, coughing up blood or mucus, weakness, and night sweats. And so that's only for the active version of TB. So if you have latent TB, you won't feel sick or have any symptoms, and you can't spread the TB bacteria to other people. And then 2 other diseases that are really similar as far as symptoms to TB are bronchitis and whooping cough. So like TB, bronchitis can also have a fever, fatigue, and a chronic cough with mucus. And then whooping cough in its later stages can result in a violent cough that leads to loss of appetite, and they can have a slight fever. And there aren't really any symptoms of TB that are unique only to TB, which can make it kind of difficult to diagnose at first, especially since it's not very common in the US. Or if it's flu season, it can also be difficult to diagnose because a lot of the symptoms are nearly identical. And the biggest difference between the two is that flu will have more of a dry cough usually, and TB, the cough is normally more wet with mucus. Okay, and then the most common type of TB is pulmonary, which is where the bacteria attacks the lungs. But it can also damage other parts of the body, like the kidneys, the spine, and the brain. And we kind of mentioned this earlier, but TB gains its entry when an individual with active TB disease in either the lungs or the throat can talk, cough, or sneeze, and then sends the droplets into the air for another person to inhale, allowing the bacteria to settle into the lungs. Treatment for TB is a pretty long process. So if you have latent TB, more than likely the doctor will choose to treat you, but it's not absolutely necessary. So if there's a reason that the doctor believes you shouldn't be on a bunch of antibiotics at that moment, or if you have like some other condition, they might choose not to treat you just because it's not causing any symptoms and you can't spread it. However, since it will more than likely show up later in life, the doctors usually choose to go ahead and treat you. But on the plus side, if you have the latent version, the antibiotics, you normally don't have to take as many at once, and it's for a much shorter period of time. But for active TB disease, the treatment is pretty long. It's usually between 6 and 9 months and includes several different types of drugs, which you can see a few of them listed on the slide. And for the first 2 months, it's common to take 3 or 4 different types of antibiotics every single day. And then you might be able to switch to 2 antibiotics a day for an additional 4 to 7 months, depending on the severity of the case. And the reason why there are so many drugs required is just because of the rise in antibiotic resistance in bacteria. So thankfully, doctors are able to take a sample of the bacteria from a patient and then identify which strain is present and determine which antibiotics are most likely to be effective. However, since there are multiple different strains and there can be different resistance, using several different antibiotics is really necessary to get rid of TB. And then multi-drug resistant TB is becoming more and more common, which is pretty concerning. It requires a combination of medications, which include both oral and injectable antibiotics, and you could be treated for 20 to 30 months.
So the current vaccine that is actually available is the BCG vaccine. It's an attenuated vaccine. It's not typically used in the United States due to just the low risk of infection, but it is given to those who are continually exposed. It is 70 to 80% effective against the most severe forms of TB, such as TB meningitis, but is least effective against pulmonary TB that affects the lungs. And it's really important to note that the pulmonary TB is the most common form but the vaccine is the least effective on it because it does not elicit a large enough immune response. Thus, this is why research is being done in the way that the vaccine is given for pulmonary TB. They're researching giving it through an IV, but it's still hypothesized that if you give it this way, it's still not going to produce a large enough immune response. But changing the dosage and the route of administration provides some hope that we'll be able to protect against pulmonary TB. So some future treatments. The current vaccine is so effective that a new one is actually not in the process of being made, but the research is going into how it's administered so that they can make strides for pulmonary TB. But due to the complexity and toxicity of the current TB drug regimens, new antibiotics are being worked on for drug-resistant TB, drug-sensitive TB, latent TB, and drugs that are given to those who have HIV. For all of these, they are working on the drugs so that the drugs are simpler, they can work in a shorter amount of times, are less toxic, have less drug interactions, and are less expensive. We're really trying to work against that antibiotic resistance, especially since the length of time that people have to be on antibiotics for this. And one thing recently in 2019, the FDA approved a combination of a few drugs for a treatment of specific type of highly treatment-resistant TB of the lungs. So that was a stride that they had made pretty recently. And then here are our questions. So which area of the body does TB attack most often? And the lungs is the most common, but it can also have an impact on kidney, spine, and brain. And then it is spread through the air when a person with TB in the lungs or throat talks, coughs, or sneezes. And if another person inhales those droplets, they can become infective. And a fun fact about that is in one sneeze, about 40,000 droplets come out, and it only takes 1 to 10 to actually infect someone. And so here's our references.
All right, awesome. Questions for Allie and Rachel?
Yeah, I do have a question. So, in one of your slides, I saw that you said someone could become infected if they cough or sneeze, but they could not pass TB by eating or drinking after them. So I was wondering, how is that possible?
It has to do with inhaling it into the lungs. So if you're eating or drinking, it's not going into the lungs. It can just go into the throat and pass through the body. Yeah.
Okay.
You have to actually inhale it through droplets in the air.
One more question?
So, can a person who has contracted TB in the past be immune to it, or they can also get it for the second time?
That's a good question. I would assume that the antibodies that they build up would help protect them, but I don't know an exact answer about if it's possible for them to get it again. I would assume it'd be similar to like getting a vaccine. You build up a strong immune response and a lot of antibodies, but I'm not 100% sure.
Do either of you know, like I know when you go and donate blood, you know, they ask you, or at least when you donate through the Red Cross, like, you know, have you been here? Have you been exposed to this? And I know they screen your blood for some things because, you know, people might not realize that they have certain things. You know, do they screen blood for tuberculosis antigens?
Yes, they do. So if you have it, they will not allow you to get blood.
Okay, cool. All right, anybody else? All right. That means our last group, Elena and Mercy.
Can everyone see the PowerPoint? Or
Mm-hmm.
Yeah, just it's half a screen.
Okay, I'll try to do the
Okay, so Elena and I are presenting typhoid fever. And typhoid is an acute systemic febrile disease caused by Salmonella typhi bacteria that are transmitted mainly through contaminated food or water. Typhoid could, when and where did we learn about typhoid? Typhoid could possibly date back to around 377 to 460 BC. That's long, long ago, just like tuberculosis, as we've heard. And many Greek physicians described clinical features resembling typhoid fever during that time. And in 1829, a French physician named Charles Alexander Louis was the first one to give the disease the name typhoid. It is difficult to determine the cause of plagues, like especially in the past, when we look at the history and infectious diseases, although some speculation is usually allowed. So some historians believe that typhoid fever was responsible for a widespread plague in Athens in 430 BC. That's way long ago, which proved fatal for 1/3 of the population, including their leader at that time, and also his successor. Jamestown, an English colony in Virginia, is also thought by some historians to have died out as a result of typhoid fever. The fever proved fatal for more than 6,000 settlers between 1607 and 1624, and may have been responsible for eliminating the entire colony. In the US, military and war environments have often been subjected to the presence of typhoid fever throughout history. In excess of 80,000 soldiers died as a result of typhoid fever or dysentery during the American Civil War. Likewise, the Spanish-American War led to infections with typhoid both on the field and in training camps. So it's just so long. The next slide. Okay, so how does typhoid really spread? It's very contagious and can be contracted by ingestion of the bacteria in contaminated food and contaminated water and drinks. And also, in some cases, it can be spread through direct contact with someone who is infected. I guess also like when somebody doesn't wash their hands, and that could kind of increase the chances of the disease being spread. In most cases, the patient with serotype typhi remain asymptomatic. So I guess just like most of the disease that we've had, and also COVID-19. So the patient might seem healthy, but they can still be able to spread the disease. The next. Okay. Who is at risk for typhoid and why are they at risk? We found that the population and groups of people that are most at risk are nations with poor sanitations and those that lack access to safe water or like clean water, and nations that practice open defecation, and those who don't wash their hands most frequently are at a higher risk of getting typhoid. Typhoid fever is most common in non-industrialized or underdeveloped countries. You'll find these countries such as Asia, Africa, Eastern Europe, and Latin America. And the highest risk is said to be in South Asia, maybe. And then most Americans only acquire typhoid when traveling in developing countries, say most westernized. And if they don't get precaution measures, they can contract the disease. Children and younger adults are thought to be at most risk because for the children, they're still developing the immunity, and for younger adults, I think they're still active. Okay, the next slide. What parts of the body does typhoid really affect? So Salmonella typhi bacteria enter digestive system after ingestion of contaminated water or food. So that's kind of the state, the start. And then they have like 3 phases. Phase 1 takes 2 weeks, and bacteria invade intestines, lymphatic tissue. And in this stage, there are usually no symptoms. The patient is just asymptomatic. And then on phase 2, that is around 10 days now, bacteria invade bloodstream, often causing toxemia, fever. And in phase 3 now, bacteria are localized in intestines and lymphoid tissue, mesenteric nodes, gallbladder, liver, spleen, occasionally bones. Lesions are caused local tissue death like necrosis. So at this stage now is when if untreated, you can see the patient is showing all those symptoms, getting weak and all that. And then the tissues and organs mostly affected are the digestive tract, bloodstream, and in some cases the skin, where you will see the rash and all that. How does the pathogen gain entry into the cell or tissue? It begins with a person ingesting contaminated food or drink, and then the bacteria, Salmonella typhi, will then move into the digestive system. And then once in the digestive system, Salmonella typhi will multiply, triggering initial symptoms such as fever, stomach pain, constipation, and whatsoever. If left untreated, the bacteria can get into the bloodstream where it can spread through the whole body. Once the bacteria is exposed to other organs within the body, life-threatening issues arises such as internal bleeding or a section of the bowel splitting open. So it's really risky.
Okay, so some of the symptoms of typhoid include fever, and usually the fever will start low, and then as it progresses, it can sometimes reach around 104 degrees. Gastrointestinal problems, diarrhea and constipation, abdominal pain, rash, weakness, and fatigue. And then it often does lead to weight loss, loss of appetite, and vomiting. 2 unique symptoms of typhoid is they get a unique rash. It's usually rose-colored spots. And one thing that you can tell a difference that it is a typhoid rash is when you apply pressure to the rash, it'll usually lose its color. And then another one is this coated or fuzzy tongue. Coated tongue was found to be one of 4 specific clinical markers for typhoid fever. And then some typhoid symptoms that are similar to other diseases. The most often disease that typhoid fever is mistaken with is a disease known as paratyphoid fever. The difference between these 2 diseases is basically the bacteria that infects it. Typhoid is caused by Salmonella typhi, whereas paratyphoid fever is caused by a bacteria called Salmonella paratyphi. Typhoid fever does have symptoms that are more severe and debilitating than paratyphoid fever, but both diseases have similar symptoms and often are mistaken for each other. They both experience fever, stomach pain, diarrhea, constipation, loss of appetite, and weakness of the body. Typhoid can be life-threatening if it's not treated. Untreated typhoid can lead to internal bleeding or a splitting of a bowel in the digestive system, which leads to the infection just spreading throughout the whole body.
So effects of typhoid on life outside just physical health. We found the case of Mary Mallon, normally commonly referred to as Typhoid Mary. She was the most widely known carrier of typhoid fever. She was the first person in the United States to be identified as a carrier of the pathogen responsible for this disease without experiencing symptoms related to the condition. And it was between the year 1902 to 1915. In those years, she was linked to several outbreaks of typhoid fever, resulting in 51 cases of illness and 3 deaths. When she repeatedly refused to cooperate with public health authorities, she was eventually taken into custody and quarantined in a state hospital. After almost 3 years, she was released, but she soon skipped parole and disappeared. 4 years later, she was apprehended again as the source of a typhoid fever outbreak that involved 25 cases and 2 deaths. Again, she was then returned to the Secure Hospital in 1915, where she stayed there until she died in 1938. The important legal issues generated by her case, including incarceration for having an infectious disease and forced surgery, were the driving forces behind the founding of the American Civil Liberties Union.
So some current typhoid treatments. As of right now, antibiotic therapy is the only effective treatment for typhoid fever. Commonly prescribed antibiotics include ciprofloxacin, or is also known as Cipro. Unfortunately, many of the Salmonella typhi bacteria are now resistant to this antibiotic. So they've started using more of a newer antibiotic known as azithromycin or Zithromax, often used if a person is unable to take ciprofloxacin or when the bacteria is resistant to ciprofloxacin. And then the last antibiotic they can do is an injectable antibiotic known as ceftriaxone, which is usually used for people who cannot be treated for ciprofloxacin, and usually this is used in younger kids. And then, do any vaccines exist? Yes. Vaccines are available to prevent typhoid fever, but their effectiveness is not always 100%. Individuals who recover from the disease often can become healthy carriers, which means they can still have, even though they might not be symptomatic, they will still have the diseases basically in their system. So to get rid of that, sometimes you might have to have a surgical removal of the gallbladder. But the 2 types of vaccine is known as Vovist, which is basically typhoid pills. It's taken orally over the course of 4 capsules, and it is made from an attenuated live bacteria. And then they also have the typhoid.
Which one, baby? Okay, you can remove it.
They also have the typhoid vaccine, which is an injectable, which is made from the inactive bacteria, and it provides for around 2 years of protection. And then possible future typhoid treatments. As of right now, the newest antibiotic that was developed is the azithromycin. I couldn't find any other information about any medications being developed, but I did find an article dealing with a new vaccine they might be developing. It's currently in phase 3 clinical trial, and investigators demonstrate the efficacy of the typhoid vaccine known as Typar TCV. As of right now, the vaccine is showing promising results in children, but they've only been following participants for around 6 months, so they're still waiting to see what the long-term effects of the vaccine is in correlation to death rates and just the well-being of patients who take the vaccine. And then our 2 disease questions is, what is one of the 2 unique symptoms of typhoid fever? So that would be either the fuzzy tongue or the unique red rash. And then, are there vaccines for typhoid? Yes, you can take it either orally or there's an injectable. And then here's our works cited.
All right, great. Any questions for Mercy and Elena?
I'm not sure if you said this, but do you know, once you get typhoid fever, how long like the whole process will be and if you can get it again.
I know the process depends with each patient that has it. It says sometimes you can be cleared in like 2 weeks, whereas others, if they waited to get treatment, it might take up to months even to just fully get the typhoid out of their system with the antibiotics and stuff. So I think it depends on every case. And about if you could get typhoid again, Mercy might know the
Yeah,
answer.
yeah. I think you can get the typhoid fever again because since it's just like spread through contaminated food and or water. I've suffered with typhoid in the past, not once, not twice, but more than 3 times when I was young. So yes, you can get it again.
Elena or Mercy, can either of you comment? I know you were talking about like like if it's resistant to a lot of antibiotics, sometimes they can remove the gallbladder. What is does it hide out in the gallbladder or what's the link there or why does that help?
I'm not quite sure, but I would assume, yeah, if it is the gallbladder being removed, it might be the area where the bacteria just kind of resonates.
Okay.
Or the bacteria is whatever would resonate, so therefore it would need to be removed just to get the whole DNA or of the bacteria out of your system, so you're not carrying the disease anymore.
All right. Any other questions? All right. So here's the deal. Good job. I'm going to stop recording here.